Good morning, everybody. It's Chris Giove here, together with Lisa Metler and Justin Ryan behind the cameras. We're super privileged to be here in Houston with Dr. Henry Mentz, who is basically the pioneer of abdominal etching as well as PEC definition, among many other papers that he's published over the years. It is a fantastic facility here. We have 7 surgeons, 2 full-time fellows, as well as a crack staff of over 100 around here. And we'd like to talk about abdominal etching with the RF as well as the PEC definition. Welcome, Dr. Mentz.
Thank you very much. Thank you very much, Chris. And I'm honored to be on your show and privileged to have you here.
No, the privilege is all ours. Can you give us a little overview of what you're going to do today, please?
Well, this patient is 54 years old. He's very fit. He's a bicyclist. Which camera am I talking to?
That one there.
This one. Mm-hmm. He's a bicyclist, and so he's got good muscular architecture underneath. He's got some softness and some excess fatty redundancy down low, in particular, some on the chest as well. And because of his age, there's some skin laxity that's working against him, particularly in the periumbilical area and in the lower chest area. So those areas in particular that will get substantial benefit utilizing BodyTite for skin tightening, and then as a second sort of benefit after the abdominal etching, we're going to do the Morpheus burst to enhance our inscriptions and get better muscular detail. So it's going to be a lot of fun. Thank you for having me here, and I hope you stay with us.
Can you give us a little, while you're working, just give us a little your thought processes and the concept that you want to illustrate to the fellows and other people in the audience?
Well, I think in particular, this will be the order for this case. We've begun with a little bit of tumescent infiltration, and following that, we're going to utilize BodyTite to get generalized skin tightening. Then we'll do our liposuction and thin out the fat pad. We'll perform some etching at the inscriptions, the linea alba and linea simulinaris here, and the inferior and lateral edge of the pectoralis major. And then to finish, we're going to use Morpheus to give us additional detail on those inscriptions and skin tightening. So I think it's going to be a fantastic blend of procedures, and that will give him a sort of a plus result. So we'll begin with liposuction. I like to use micro-air for these guys, and we'll just begin with some liposuction in these areas first. I'll first thin the fat pad primarily, and then well, let's do we have our BodyTite ready? Let's get that set up. So I'm going to thin the fat pad a bit, and then we'll begin with the BodyTite. Okay.
So that brings up an issue that a lot of our colleagues that use the InMode devices, 2-mesh RF then suction, or 2-mesh suction and RF, or what order do you prefer? Because you do more of a subtle changes. You're doing differential liposuction. You do the seminal papers.
I think the biggest benefit on using RF in the initial part of the operation, it allows better skin tightening, and therefore your endpoint is shifted. So prior to BodyTite, we would liposuction to a point where we're just beginning to see some laxity, and that would be our endpoint. Mm-hmm. But if we use BodyTite early on in the procedure, the endpoint shifts, and we're allowed to do more aggressive liposuction. So I'm just going to thin it a little bit on the deep side, and then once we're set with the BodyTite, we'll begin with the BodyTite, which will be about 1 centimeter deep for this area. Okay, so we've just thinned in this periumbilical subscarpa area a bit, and now we're set up for the BodyTite. And I'd prefer to do my BodyTites in quadrants. So we'll run it, that's okay, sort of like this. So 1, 2, 3, 4, 5, 6. Mm-hmm. That's going to be our target. And I'll start down low first. From this port, you can see I can get pretty far around. It's sort of this wheelhouse. I'll make another puncture at the umbilicus and sort of roll here. And then in this periareolar area, I can reach here. So the overlap really gives us good coverage, and the incisions are relatively tight. Now when we do a little bit of bonus up in here. I might make a little port here and here just to give us a little extra. And here you could just listen to the dings and it makes it very convenient. So I'm just running over a singular area sort of back and forth, spreading out the heat and the energy. And sometimes I go too fast, sometimes I go too slow, but the advantage on this device is the safety. Because internally it measures the temperature and it turns off. There's our 3 dings, I don't know if you heard it, but that means our inside temperature is at 68, which is good, that's where we want to be. Our outside temperature is not quite there yet, but I can't see it on the screen. But the safety of this device is fantastic because it measures these temperatures acutely in milliseconds, I believe. And you get a good idea of where you are. There's the 3 dings again, and that's our internal temperature hitting 68. And I'm going to move to the next space. Good morning. Thank you so much for joining us. We're here at InMode University, and we have a patient to show you this morning. We're going to do some abdominal etching. We're going to do some body contouring. We're going to do some skin tightening with InMode's Morpheus and InMode's BodyTite devices. And it's going to be an exciting new case today. We'll show you how to do abdominal etching and a super etch with that. So it's going to be a lot of fun. This is our patient. He's 54 years old, athletic guy. He does a lot of cycling. He's gained a few pounds with COVID, but otherwise he's got great muscular architecture underneath. He's got some soft tissue in the chest, in the love handle, and the abdomen. And you can see the laxity there. You can see some laxity around the umbilicus as well. He's got a little bit of horizontal shaping of the umbilicus, indicating some laxity here. And he's got some roundness in the love handle. And so these are areas we're going to address with liposuction for body reduction. These are areas we're going to address with skin tightening with BodyTite. And we're going to address with abdominal etching and Morpheus in order to get better muscular architecture. So it should be a lot of fun. And hope you stay with us. It's going to take a bit, but it'll be a lot of fun. A lot easier than going to a $40,000 course and you get the same thing for free. So InMode is very generous with this offering. So with our patient, you can see he's got nice pectoral fullness. And what I'd like to do first is mark the midline. So we do the sternal notch, the xiphoid. Hope that looks centered. I'd like to mark the lateral edge of the pectoral muscle and the inferior edge. Played high school football, so there's some stretch marks. He was a much more athletic guy when he was 18, but here we are. So there's some fullness in the axilla. This is going to be straight up liposuction. There's some fullness over the pectoral muscle. We'll reduce this some. There may be some gynecomastia present here that we'll take out separately. We'll treat this entire area with BodyTite for skin tightening, and we'll treat this area with Morpheus for selected tightening, and maybe some around the areola as well to tighten this periareolar area. On the abdomen, I'd like to first mark the midline. And the edge of the rectus muscle. And you can see, he's got nice athletic fullness and muscular fullness over the rectus muscle. Over the obliques, it's nice and thin. And you can see the muscular thickness here versus here. It's quite different. And so naturally, there's some architecture that's different on the abdomen. Usually, it's about 3 times thicker over the rectus muscle versus the obliques. As you see this difference right here, I can't quite grab it. But maybe 4 centimeters or so, centimeter and a half. So we want to maintain some of that differential architecture so that we keep the rectus muscle appearing prominent. You can see sort of below scarpas, there's a separate amount of fullness that's related to that second layer of fat. Over the flanks, there's some extra fullness there and some roundness there. I'll mark the edge of the semilunaris coming down to the inguinal area. And now tighten up your stomach for me. And you can see some architecture here with the first two inscriptions. The third is going to be right about here. And so that's the beginning of our marks for the etching. You can relax now. So it's important to mark these patients in a standing position before you do the three-dimensional contouring here, because with the amount of movement and laxity he has here, if you mark these patients lying down, there's about a centimeter or a 2 centimeter shift in the architecture, so you don't want the etched area to be above where the actual inscription is. So we'll mark the edges of the rectus muscle and the inscriptions as well. I don't like for these to be too checkerboard-like. It's nice that there's some taper from the edge of the pectoral muscle down to the inguinal ligament, as you can see here. Sometimes this uppermost inscription is very close to the inferior edge of the pectoral muscle, and sometimes they're even continuous, but he's got a little break between the two, which is nice. And it's okay if they're a little bit asymmetric, because that's the way the body's built. So I'm going to mark these a little bit more heavily because I want them to stay on through our prep. And when we do the etch, we'll do the etching at the linea alba, the semilunaris, this little strip right here, the transverse inscriptions, and then I'm going to mark down low here this inguinal area, this sort of Abercrombie etch, this little area down here. It's nice to see that as well. There's no inscription down below the umbilicus, but there is an inscription right here. So the areas that will, well, in review, our plan is going to be for BodyTite, for skin tightening, generalized skin tightening, here and here. Secondly, we'll do liposuction to reduce the fatty pad thickness through here and across the abdomen and flanks. Thirdly, we're going to thin out the areas that are most important over the love handles, over the oblique muscle. We're going to thin out especially this area lateral to the pectoral muscle. We'll perform etching at the linea alba, the semilunaris, transverse inscriptions. We'll leave the fat pad a little thicker over the muscle belly of the rectus muscles and a little thicker over the muscle belly of the pectoral muscle. And then finally, we're going to do a little flourish, and that's going to be with our Morpheus burst, and we'll tailor these areas to get a little extra tightening here. And that's going to be the polish at the end. So it's going to be a lot of fun. Really looking forward to this, and I think he's set for a really dramatic result and a great result.
And we're back.
All right. Well, thank you, Dr. Chia. We finished these two lower quadrants. We've gotten about 10 kilojoules per quadrant. I'm working on this epigastric area, and I'm at around 5 kilojoules there. And then when we move up here, I'm going to have Dr. Garlick do a little bit more BodyTite in this left chest and right epigastric area. while I'm doing some liposuction on the flanks, because that's kind of boring. And we'll be able to get some of that done before we start on the abdominal stuff, which will be far more interesting.
Now, are you going to apply the radiofrequency in different depths, just like you are painstakingly doing it for the etching to follow, or do you move more superficially where you're etching, for instance?
Well, I'd like to, we're going to depend some on the Morpheus to give us more superficial radiofrequency energy. However, in this sort of periumbilical area, that's always an area that's kind of resistant to contraction. So I think doing some in scarpas and some just above scarpas gives us some advantage. So maybe a double thickness in this area because we need it.
What were the challenges you had when you first started using this?
I think more anxiety, frankly, just because you never really, it takes a while and you'll end up beginning with some reservation. Beginning with some reservation, and I probably started, I got it, Chris. All right, it's on your side now. I probably started doing 5 kilojoules per spot, and I still had good results, but I'm getting more brave now, and I think my results are better, you know, achieving endpoints where there is a little bit more heat delivered, a little bit more energy delivered, and so more contraction in the fibrous network that's underneath, and more skin tightening. I think the Morpheus, in addition to that, is going to be the plus. And it's a great advantage. But you know, I gave a talk a while back, and I was criticizing aesthetic plastic surgeons because reconstructive surgeons, plastic surgeons, have done a far better job in creativity. You think we'd be the creative ones, but reconstructive plastic surgeons have doubled in the last 30 years, and the number of aesthetic procedures has been the same. So those guys have really, a lot of new flaps, a lot of new techniques, tons of craniofacial. They have really passed us up, and we came up with liposuction 30 years ago, and that's really been about it. There hadn't been a whole lot beyond that, and I think this is the best advance that we've had in 30 years. I think it's changing. You know, liposuction doubled the number of procedures that aesthetic plastic surgeons did from 1980 to 1995. It doubled, and then it's been flat since.
What are your thoughts on where you're depositing energy and where you think the vectors are tightening, what you're looking for?
Oh, it's a tricky question. I mean, I think I'm really generally just doing circumferential stuff here. We're going to use the Morpheus to sort of enhance the muscular edge there. But I think with females, I would suspect it's mostly vertical, but probably periareolar as well, in a radial pattern. And what's your experience?
I agree with you because, Jacob has the most experience with the female breast, and he says in the properly selected patients he gets up to 2 cm of lift at the NAC.
Yes, that's been my experience as well. 2 to 3 centimeters, and it's surprising. I didn't think it would be that.
I would agree. But in the male, obviously, you don't want that. That's why you're kind of just going all the way around. And you had that paper where you had that single access PEC contouring. Now, what are your thoughts? That was obviously contouring by subtraction, but now you're adding the RF. Same kind of principle, would you say?
Yeah, I think so. Same. I think as far as the liposuction goes, you for athletic patients and sort of full-shouldered patients, it's important not to take off too much fat because you want to leave some fullness just like you do on the rectus muscle, and you don't want to leave them sort of adolescent appearing in the chest. But leaving some fullness there helps some. Yeah, I did.
And I think you taught us that you probably want to even maintain or even augment the superior pole of the male chest as well.
Yes, I agree.
Do you do fat grafting sometimes, or?
Rarely, but I have, and I have fat grafted a handful of patients that have been sort of over-suctioned.
Yeah, definitely.
The other problem that I've seen on sort of full-chested males, he's going to be easier, but a lot of times when you reduce the bulk substantially, you have areolar redundancy and kind of a crinkled looking areola that looks a little embarrassing. And so I think the Morpheus is going to be our strategy there. I think my plan is we're going to do Morpheus in the etched areas and also in the periareolar area too, so that we don't have that little
overhang or indent. Yeah.
Sort of folded areola that's you do your best to create an abdomen and a chest for these guys that they'll feel good about taking their shirt off at the beach. But if they have some distortion in the areola or really anything that calls attention to surgical artifact, it just looks funny. And the Morpheus, I think, is going to be a great way to sort of reduce some of that areolar laxity. Where am I now? Do you know? I think I'm pretty good here.
Yeah. Internal temperature is good. And what are your indications for glandular excision? When do you go to that as an adjunct to your?
Oh, that's a great question. Because sometimes I'll liposuction the chest, and it's really all fatty. There's very little glandular tissue. Patients in particular who've done steroids, who are doing pellets and assortment of things, sometimes the protein shakes will create a little bit more glandular hypertrophy. On those patients, we'll find there is some glandular hypertrophy. I'll do my liposuction first and thin it out and really achieve the I think I'm done. Jerry, you ready to do the other side? But achieve the contour that I want, and then oftentimes there's a sort of a button or a cookie of glandular tissue that's under the areola that is obvious. And so I finish the suction first, and if there's a button or a cookie sort of underneath the areola that's glandular, it's very obvious. And I'll do that through a puncture excision. I dissect above and below the glandular tissue and then take it out piecemeal. I try my best not to create this sort of smile pattern areolar incision, because it is sometimes obvious, and so you do your best to create a result that patients are proud of and they can take their shirt off at the beach. But if they have a little smiley on each areola, it's sometimes quite obvious, and so you just want to give them the freedom of lifestyle that a handsome chest will give them, and I think giving them an athletic contour, giving them muscular definition that looks good, and reducing surgical artifact is really the key.
Yeah, absolutely. Same tenets apply.
And if we could only have painless surgery, that would be everything. But yes.
So we have a question from the audience. She says, seems to be depositing energy continuously. Can you comment on whether it's best to apply energy unidirectional or bidirectional?
Oh, I say like cross tunnel?
Or is it,
Maybe that's the question?
she mean back and forth?
Keeping it going like this.
I see what you're saying, yes. I think the safest strategy is to just do retrograde energy. But if you've pre-tunneled nicely and you're not going to pop too superficially, I think it's pretty easy to go back and forth. So I think pre-tunneling is probably the key to that equation. And if you have to take your foot off the pedal on half strokes, then it takes twice as long. So you can deliver twice as much energy. That's a good question, because there's several other things I think that seem important. When I started, I would sort of fan it and do a quadrant and go back and forth like a windshield wiper. And it takes forever to create enough energy and heat to get collagen contraction. And so I've learned from these guys that the best way is to stay along one corridor until you achieve your endpoint and then shift up. And that way, you see me walk around a bit because I'm not as good as some of these young guys, but I lose focus.
We all do.
But the best way to do it is one step at a time. And if you can keep the energy going both ways, that's good. But it's a little more dangerous because you don't want an end hit.
Right.
The end hit on the tip of the probe is one way you can get too much heat in one spot. So if you pre-tunneled, you should be pretty safe.
So how do you know depth? How do you know if you're too superficial or if you're too deep? How do you decide?
Well, it's pretty tricky there, I think. Maybe you'll have some suggestions, but I think the pre-tunneling, because with a larger cannula, it's with a larger cannula you can kind of feel where you are, and if you're wandering a little too superficially, you can kind of feel it. I think pre-tunneling with a stiff cannula helps, because the tip of the probe is a little bit noodly, and can
The
wander
smaller
a
ones
bit.
especially, yep.
Yeah, so if you pre-tunnel with a stiffer cannula, now you've got a plane that's a little safer, and I think that's the easiest way to do it. Same with the FaceTite as well.
Definitely.
Any thoughts there,
No,
Chris?
definitely, totally agree with that. So basically, if it's easy to pass, do it. If not, definitely pre-tunnel and define the layer you want to go.
I started doing retrograde only because I was a little nervous, and maybe that's the best way to start.
Right.
But once you get some sort of confidence in where you are, then I think it's faster. You'll save 30% on your time frame just going both ways.
Unless you're going around a curve,
Yes. Yeah.
just to make that point.
Yeah.
No, totally agree with that. Great. Now, do you, since you have the benefit of having help, do you usually simultaneously suction and RF, if that's something you do?
I do.
Or,
It just makes a lot of noise,
Yeah.
but if you'd like for me to do some suction on the flank, it'll speed things up.
Yeah,
because
whatever you do normally, this is totally what you normally do.
We still have 2 other areas to
Sure.
go.
But if you
Right?
do something, yeah, if you have the benefit of
You done here? Yes.
having another surgeon.
This done, this done, this done,
Okay.
this done, this done.
Okay, so we're almost
Great.
done. And how
Yeah.
much energy do we have? We're at 55. So we'll probably get close to 60 on a kilojoules, and then we can start with suction.
Great.
I'll-
The audience and myself would love to see how you do it, as if we weren't here or whatever.
Okay. So while Dr. Garlick is finishing, we'll start with the liposuction on the flanks because it's less interesting. And it's basically just debulking here, and we'll save some time by doing this on the front end.
And Jerry Pittman used to call it FAL, Fellow Assisted Liposuction, when we went back in the day.
That's right.
Actually, Ryan, if you don't mind putting up the second video where Dr. Mentz talks about the gap patient, that might be a good time to do it. Yeah.
So this is a patient who we might otherwise say has too much skin laxity for full abdominal etching and a more aggressive liposuction. Because he's a little bit older, 54, he's got some roundness here that we want to translate to flatness, so we're going to create some skin laxity. So generally this is a patient who I would have said, we can do aggressive liposuction, but you're going to suffer with some skin laxity in the finish. And laxity above the umbilicus, laxity in the periareolar area, you may not be happy with that. So oftentimes with this kind of case, we'd have to back off. And we do a more restrained liposuction as a result of that. And on the flip side, this is a patient who doesn't want a scar. He's young, he's not that young, but he's 54, but he's fit. He doesn't want a scar here. He doesn't want a scar here. And really, he's in that in-between group that really benefits from this new technology. It allows for skin tightening in the areas where we're going to create skin laxity with the liposuction. And that's the real advantage in this new technology. It has expanded our demographic for patients from those patients who are tight-skinned with some soft tissue fullness to those in-between patients who would generally be no man's land. They don't want a scar and they don't want skin laxity. So he's a perfect patient for this. And this is a group of patients we've neglected for a long time. And InMode has a new technology that allows us to find satisfaction here. So very grateful to InMode with this new technology. Okay.
We're back. Any final thoughts on the gap patient, like the gap treatment protocol for the in-betweener, as it were?
Well, I think the more you use it, the more you're likely to find gap patients. In the beginning, I was a little reluctant because I wasn't sure of the end result. But I think as you use the BodyTite device, and I think tethered with the Morpheus as well, results continue to improve, and so the treatment gap patients, that qualifies more and more patients.
Increases your demographic. Yeah.
Yes, increases the demographic. I think it's fantastic.
Yeah. Great. We'll go to Dr. Mentz's slides here, and you can monitor yourself right there.
Okay. So like with this athletic male torso, most guys want to be thinner, but in the end, they also want architecture. even older guys. So I have guys coming in who are 65 who want liposuction, but everybody wants a little bit more architecture. And so the linea alba, simulinaris, the transverse inscriptions, and the pectoral sort of slab are important to define so that patients have a more athletic appearance. Let's see if that video will run. The next slide.
Yes, please.
So this is a slide of a patient after etching, and you can see where we've etched, there's a little bit more erythema, but you can see when I put the cannula in and lift it, you'll see a little bit more fat over the muscle belly and less fat over the inscription. And that allows that better definition. You can see when I lift on the other side, the same thing. Maybe a 1.5 centimeter pinch on the muscle belly and a 0.5 centimeter on the inscription. And that will give you a nice architecture without it looking too artificial. I think, I have seen some patients who look a little over-contoured. And so, ab etching is really a great advantage with liposuction. But I think if you make it look a little too geometric, or if you make it look a little too hard etched, and it doesn't match the rest of their architecture, if they have soft shoulders and soft arms and a six-pack, it just looks funny.
Yeah.
So you have to avoid, you can give them some architecture, but you have to avoid overdoing those patients. Let's see. Let's go to
The next
slide 3. And you can see on slide 3, this would be my strategy for someone with skinny arms, kind of like me, with skinny arms, not a lot of bulk in their shoulders and trapezius and deltoids, and you just give them a little bit more linea alba and simulinaris.
You basically define these areas in your 1993 paper. So for the audience and myself, where can you attack it a little more aggressively aside from those areas? What would you say? Like you call the Abercrombie and Fitch line, like the external oblique, are those areas that you can be more aggressive as well?
Yeah, let's go to the next slide. So for patients that are more heavily muscled in the shoulders and in the arms and legs as well, and basically if they have matching luggage, those are patients you can give more architecture, and you could do it, you see, on the rectus muscle to give them more architecture there. And even on that sort of Abercrombie line, the inguinal ligament area, and give them that look. And I mean, young guys are really looking for that because I guess because they're taking a lot of selfies and they want to look good all the way down low.
Yeah, whatever brings in the patients is we're all for it.
So we see patients that are looking for abdominal etching with sort of full out etch with linea alba, simulinaris, transverse inscriptions, and the inguinal ligament. So that's an example of a patient that wants the full thing. And go to the next slide. So on the next slide is I'd say half of the patients that come in for male contouring on the abdomen, they have softness in the chest. And they have some roundness in the breast that gives them sort of a feminine look. And if you do a etch on that patient and leave them breasty, it looks funny. And so finishing out the chest by sort of etching in the lateral and inferior edge of the pec, and also being more aggressive on the axilla, can give them more definition and a better look. So this next slide, we can see the linea alba, simulinaris, and they're kind of walking through these. This will be part of our etch strategy.
Perfect.
But I don't like to use incisions at the midline. I used to a long time ago, but they're far more obvious. So there's a way to kind of use these lower lateral incisions to kind of sneak over and do these inscriptions and finish it out without having to put punctures in the middle.
I have a question.
Very timely.
Where are you making the incisions to define the transverse inscriptions?
So just as you see here, so the areolar incision and the lower abdominal incisions we can use to kind of swing across, and I'll show you that in a few minutes. So the cheat is that you can kind of bend around to get there without having to use incisions at the midline. Now and then, you know, patients like this that are Fitzpatrick 4, you make incisions here, and then
May we go live, please?
That's okay.
Yeah.
Okay.
Actually, I didn't know. That's important for the
Okay.
audience to see that. Yeah, there you
Have a
go.
pen?
Yep.
Yeah, big one.
Yeah.
So now and then, in the old days, I used to make an incision here, 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 and here. And on patients like this, they show up at the beach and they've got a little hyperpigmented mark there,
Right.
and a six-pack, and it's a tell.
Yes,
You
definitely.
know, people can see that as something that looks a little bit funny. Let's see where you are.
Are you using those right angle cannulas nowadays, or
No.
bending them?
I just bend this one.
yeah.
It's pretty easy, and there are other ways to do it too. I call it pinch etching, but I'll show you in just a minute how we get to that. But I think we're almost done with flank. That looks very good.
Do you ever liposuction in a decubitus position?
I'm sorry?
In a decube position, you ever suction?
Yes.
Yeah.
Yeah, we'll have to turn him to do the back. And I think we'll do that at the end of the video because it's more boring.
Perfect. Yeah.
But yeah, in order to get the back side of the
All the way to this.
love handle, when we turn that incision, I put at the top of the gluteal crease. You know, at the top of the midline crease.
Yep.
So that it's pretty hard to follow.
Hard to find.
I don't like incisions that are
Too
that are
symmetrical.
staggered over the top of the buttock, because again they look quite obvious as well. Okay, I think we're good up here. Yeah. Okay, so we got our flanks almost done, and so we'll begin on the chest. I mean, on the abdomen and the chest now, and I'll start here, and I'm just going to begin to thin the fat pad with a goal of maybe 1.5 centimeters or so, and I'm going from deep to superficial.
Okay.
People do it different ways, but
That always made sense to me, the way you do it.
Yeah.
Yeah. And then Lisa's going to go over some of the settings for the Morpheus and discuss it with Dr. Mentz, if that's okay.
oh, good. Okay.
We have a 40 pin up here, right? So we're going to do
Right.
the Morpheus body. And the depth goes all the way up to 7 millimeters. Energy, we discussed this earlier. We're going to use an energy of 30 today. Is that correct?
Yes. The blue handpiece.
Okay. Different modes on this. Cycle, meaning the pins come out and back in. Fix, the pins come out and stay out, and you deliver energy. And then this is our new technology, the burst mode. So it will deposit in different depths. So we're going to do a depth of 7 millimeters, 5 millimeters, and 3 millimeters. And we have a couple slides that we'll go through while you're finishing this up. And we'll describe how that works.
Okay.
Okay?
Yeah, I apologize for jumping around, but if we can go back to Dr. Mentz here, and he can talk about his PEC strategy, etching strategy for the PEC, with the next slide. Now they're working up the chest.
So I'm working on the axilla right here,
Okay.
just lateral to the pec, and thinning that out some. He didn't have a lot of fat there, but it will give us better architecture. And so for the pec etch, you can etch that from sort of a side-armed approach as well. So once you get the pectoral muscle slab, sort of the pectoral area fat slab sort of more geometrically shaped, you can etch in the lateral and inferior edge. And the lateral edge I'll do from the axilla, and I'll do from the periareolar incision. And the inferior edge I'll do from the opposite side. So after etching, we generally use foam padding in the areas of the etch. And the nice thing is, if you don't pad patients, when you take off their garment, it looks very flat because there's more edema where you've done the etching, and
Yes.
so it looks invisible. It looks like you
Right.
haven't done much.
Right.
And so if you use the padding, it gives them sort of an unveiling.
Squeeze it, yeah.
It's kind of like when people go to their house that's been redone, you know, that,
Yeah.
that thing. So it gives them a nice little bit of wow.
Yeah.
When you take the stuff off, it does look a little funny on the front end.
Right.
But then I like to use a garment that has a crew neck. And you see the neck is broader.
Yes.
And the reason for that is these patients, if you do their chest, they can't get a regular neck garment over. They have to put it over their shoulders. It's way too painful for them. And so that sort of t-shirt, they're able to step into the neck
I see.
and pull it up like a women's bathing suit. Guys don't like it when I say that, but it seems like that explains it.
It
you know
makes
what I mean?
sense, yeah. How long do you leave the foam on?
Just a week.
A week, okay.
So it comes off after a week, and then we keep them in the garment for 6 weeks.
6 weeks.
And the garment's actually pretty easy to wear. They don't like it for the first couple of days. Actually, the garment that we use initially is a zippered garment because it's a lot easier to put on,
To put on and off, yeah.
when they have pain. And here's a patient we did kind of a soft etch on. You can see that he's got some definition, the linealis and singularis, and he's got a little definition in the rectus muscles that really have just come with unveiling. We haven't etched him, but you know, a lot of guys, when you do their surgery, you know, you can see his before picture. He doesn't really have a lot of muscle bulk. He's pretty soft. And you do the liposuction, and they're encouraged to go to the gym and that kind of thing, and then the muscles pop out after they're unveiled. And so that's a good example of a soft etch that has really done his part to improve his result. Let's go to the next one. So here's another one, sort of the same kind of thing. You can see before he looks a little bit soft in the chest and in the torso. And he's a little like this one, maybe a little younger. You know, his skin looks a little tighter on the pre-op than this fella's, but you can see on the after picture, you know, he's leaned out well. You can see architecture kind of coming through, and that's a result that's got a good tail on it.
Yeah.
He sent me a picture 2 or 3 years later. He just finished a marathon without a shirt on.
Yeah.
So, you know,
That's validation.
that was good validation, yeah.
So,
All right, let's go to the next one, and you'll see the next ones will be.
now this gentleman has, that patient has thicker skin than the previous patient. Do you change your strategy? Is just a little more elbow grease? I mean, do you
A little bit more elbow grease, but I think the reason I have that in there is this is a guy who visibly has much more muscle bulk in trapezius and the biceps and deltoids, and so you could do a full etch on him, and it looks right.
Yeah.
You know, it doesn't look artificial. I think I might have to do some more tumescent. Do a little bit more right here. I'm gonna do a little tumescent right here. I'm hitting a juicy spot. Okay.
Yeah, I see what you mean by the proportions. The shoulder girdle, the horizontal width, that's a match. Yeah.
Yeah, he did very well. Let's go to the next one. Okay, so this is a patient, we see these now and then, but a young patient, and he lost about 130 pounds. And this patient I think would be tough even with BodyTite. But we did a body lift on him. So he does have a scar, you can see it. But we did the body lift, and then in the tail end, you know, after his body lift, we did an etch maybe 6 months after.
Okay, that's my question. So you delay it by 6 months.
Yeah, I think if you're doing etching, it's a mistake. Give me a wet and a dry. It's a mistake to do here. To do the transverse inscriptions at the same time you're raising a flap, because you're coming across the intercostal vessels.
Exactly. Yeah.
So in those cases, I'll delay it. Okay, I'll try again here. It's just kind of red. Your side looks better. I'm a little bit red right here, so.
We have a question about the garment.
Yeah.
Where do you get the male garment?
Do you know, Lynn? We'll pull one. I think it's Marina. Marina. Let's pull one. We can take a picture of it. Marina, I think, makes a good one. I think several people have garments similar, but the open neck garment is really the key, because if you're doing their chest, it's impossible to get that thing on over your shoulders. Okay, we'll come back here.
Yeah, while waiting for that, we'll go to the last male before and after, or rather, of this series. Yep.
Here's a good case with, well, he's a younger patient, fortunately, but this was without BodyTite, but I certainly would use BodyTite on this case. I mean, this guy was like maybe 16, 18, and had a lot of fullness in the chest. You can see his areola is large. And so that kind of case, if he were 30 or 35 years old, there would be a substantial amount of skin redundancy with that, and even sort of a pickled look on the areola. So I think the Morpheus on the areola, on that case in particular, would be especially good.
Here and just show it in front of it. We'll go to camera 2, please, and then Becky will show, it's that camera, the garment, and Lisa will show you the label.
Oh,
one second.
that's the OR one. Do you have one that's the post-op one? Okay.
That's Morena, right?
So that's the garment we use at the time of surgery. That's got the clips on it, and that's easy to get the bandages on and off. The garment that I had on screen earlier was one we used after the first week, and it works quite well. Like I said, I think there are a couple of companies that make those garments, but we like Morena. I think that they're especially good and provide a nice garment that seems to be really durable. Those early garments way back, it seemed like after 20 washes they get a little slack.
Yep.
But the garment technology has improved substantially. His chest is working out pretty well. You can see the BodyTite is really giving him some firmness there. I'm just giving him a little bit more edge, and I'm not feeling a lot of gynecomastia element, glandular element here. So, sorry, it's
coming out pretty good.
It feels okay. I'm just kind of thinning the fat pad some. I don't feel that button or cookie of glandular tissue that's redundant there. And I'm just trying to give it a little bit more.
That's a really nice change already. Beautiful.
Yeah, it's really coming along nicely. You can see in the picture, let's see. You can see he's got, you can see a nicely developed linea alba, and you see the cannula. So you can see here, on the linea alba, I'm really down to the skin. Really all the way up to the xiphoid.
Yeah.
And you can see on the rectus muscle sort of corridor, you can see thickness over the muscle belly, thin over the inscription, thick and thin, thick and thin, and it gets thinner as we go down. In a way, I kind of like to leave the upper muscle bellies a little thicker.
Makes sense.
Because if you make them all the same, sometimes if they're a little lax in the abdominal musculature, then they look like they have a little pooch left. So I go thicker to thinner, and inscriptions super thin, and oblique. I don't know if you can see this. Oblique, super thin. You see that? Yep. And there's the edge here. You can see over the obliques here, quite thin. Over the rectus, a little thicker. Over the muscle, a little thicker, and over the obliques, a little thinner. So he has nice sort of delicate definition there that I think this is a pretty good endpoint for him. Turn the suction off for a second.
So far, this looks great.
So I think, we still have the back of the flanks to do. We're going to do that as we turn, but I don't think that's important for y'all. But I think we can do the Morpheus to give him some definition here. So you have a pen?
Fantastic.
Can you show this?
So I'm outlining the areas that we're considering. Actually, I don't want to do the rest on foam.
Okay.
So sorry, because there were one or two cases with it with hyperpigmentation, and so I mean we use foam now and then and to augment the procedure, and I think you have to pick which one's best for you.
Got it.
So I'm outlining the edge of the rectus muscle and the inscriptions as well, same as the marks we had before. And these are the areas we're going to use the burst to give us a little extra bonus here. And then I need to do a little more liposuction here, but I want to etch in. I think I need a bigger pen, Hilda. There we go. So we'll give a little Abercrombie and Fitch. I hope they don't get sued here. So.
I think they're going out of business anyway.
Oh, yeah, that's right. So whatever. This is the Abercrombie mark right here. We call it the Mentz mark, okay? So anyway. Anyway.
There you go.
So this is where we'll be as far as our Morpheus. And I think that's going to be great. And I probably will do a little more bonus right here as well. Okay, perfect.
All right.
So we have our Morpheus device.
Yes. Do you want to overlay some gloves or like for Dr. Mentz?
Yeah, okay.
So as a reminder, I mean, everyone in the audience is a user, but the tips are obviously sterile, but the hand pieces are just cleaned. Yeah.
So when we do the flanks, we'll do a reprep.
Reprep, exactly.
Yeah. So this is the coolest new technology I've seen in a long time. Even cooler than the original stuff. So
Great.
the nice thing about this blue gun is the tips you attach, and these are per patient.
Let me put it back on so you can see a little bit.
Okay. Yeah. They have 40 pins, so you can see those pins sticking out. I don't know if you can see them there.
It's hard to see.
Maybe I'll do one of these. But this is a 40 pin. Are you focused there? Just tell me when.
Closer.
Okay. So this is the new tip, and you can see it comes out 7-8 millimeters.
It does.
And you can vary the amount, the depth of the tips, depending on how you gauge your machine. And so the coolest thing about this, it allows you to do 3 different levels at the same time. The older machines were just a single level and far more superficial. The newer devices, InMode's devices, they allowed you to do different levels with the same device. You see those pins? If you can see the pins come up, let me put it here. You can see the pins come up. And allows you to do different levels at the same time. So it saves you a lot of time. So this just clips on, and down foot pedal here? Oh, here. And I don't know if you can see this maybe against my shirt. Are you focused here?
Yeah.
Oh, can you see it?
Yeah, that's
Okay,
great.
so when I hit the foot pedal, you'll see, grab that ruler. So when I hit the foot pedal, you'll see the pins come out at 3 different levels.
Deep, intermediate, superficial, in other words.
Yes. So it's running here 7 millimeters, 5 millimeters, and 3. So with a single stroke, you get 3 pops, and that saves you a lot of time, where before you'd have to do the whole thing 3 millimeters, the whole thing 4 millimeters, and they didn't have 6, 7, 8 back then. But this allows you to go a lot faster and also a lot better. And there's some advantages using the same port, right?
Right, because the tissue doesn't have time to cool in between, so the coagulative effect is actually greater. So in some, it's a more aggressive than doing it in sequence and then coming back to it.
Yeah. So I'll start. I'm going to do the lineal, and then Abby's going to do the left side, and I'll do the right side. And our treatment overlap, you can see the width. Well, it might be 2.5 centimeters or so.
Yeah, it's a little bit wider than the standard 40 pin.
Yeah, and then the treatment width is really more like 2 centimeters. So I'm going to go sort of 2 passes and overlap 50% or so at the middle, 50, 70%, okay? I'll start at the top.
Hands.
You have to push a little harder with this device. What you don't want to happen is for the skin to be pushed away from the tip.
Exactly.
And so the tip ends burn the patient. So you have to be sure you're pushing hard enough.
It's got a pretty good kick to it, so you gotta, yeah, I'm glad you mentioned that, because for those of us who use a regular Morpheus, it pushes,
So what's going on?
pushes hard back.
Okay.
Yeah. Is it clicked? Yeah.
Okay. Okay. Okay, good. Okay, better. Okay, we're back in sync.
Yeah, saves time, a little bit more aggressive, in my opinion, and yeah, the variable
skin
depth
for me
really
here.
is great. So Dr. Rodriguez is helping splay the tissue out a little bit.
If on a patient under general anesthesia, their belly's sort of soft, and what you don't want is the skin to be pushed away and for the treatment tips to burn the surface of the skin. So sometimes you have to, on a patient who's asleep, you have to tighten the skin so that you get through the skin effectively.
For those of us who do it on the awake patients, what analgesic modalities have you heard around the country, Lisa? The way we do it, Spiro and I do it, we use a triple, and with or without tumescent, depending on the squirreliness of the patient, and a little Pronox. What do you like to prevent
So
your patients?
people use a variety of tumescent or using the mesocaine device to tumesce, or with a spinal needle, or a topical 23% lidocaine, 7% tetracaine in a plasticized gel, and Pronox is key. Most people can get through this with topical and Pronox, but not at the deeper levels.
Yeah, it's definitely effective and it's stimulating, but
Okay.
well worth it.
Let me do this side first, Abby, and then you can do this side next. Okay, so I'm going to do simulinaris next. I'm going to start really at the top here. So we're doing the lateral edge of the pec muscle here to give us a little bit more definition kind of coming through. And it's easier, in fact, to do it over the rib cage because there's a little bit of bedrock underneath it.
Right. It's like a foundation.
Now that may have been, that bump right there may have hit the rib. And so it didn't run because it hit the bone. So that's another little safety precaution for this device.
Nice. Yeah, you're not getting any warning sounds, but it's very safe because if you don't have good contact, it'll bonk you out. And not deliver the energy.
Okay, I'm going to go right here, inscriptions.
Before the burst, were you doing 2 or 3 passes? Henry, were you, or just,
Yes.
Yeah.
I'm going, the inscriptions I'm doing twice, so 2 passes, and here again.
I like this because it's kind of like a second bite at the apple in terms of the tightening, I think.
It really is.
From a
I mean,
different direction.
I think it makes it a lot of fun. So the same thing there, but it makes it a lot of fun. You can get a little bit more bang out of your etches.
While we're doing that, we'll go to some of the slides that illustrate
Okay.
the device.
Okay, Abby. Same kind of thing, I think, from the top down. Here, you need the foot
Yep.
pedal. Could you pass the foot pedal to Abby?
And then just do a picture-in-picture live, please. All right,
And
this
Hilda,
is, while we're continuing with the Morpheus, this is just some prepared slides, just showing the depth of deposition. And it's definitely quicker, more efficient, and I think you do get more of a coagulative effect, so it's a more aggressive. Next, please.
There you go.
There's a lot of words on these slides, but I think Dr. Mentz said it best. It's really a nice way to reapply the RF in a different direction, especially if you're doing BodyTite, and also you can do it as a standalone procedure. I mean, you're doing tons
Push a
of those in
little harder
Michigan,
there. I see
right?
it lifting
And
up.
just
Good.
as M8s by themselves. And I think the burst part's going to be another thing that you can offer your patients. Next, please. Yeah, that's the one. That's a picture.
Oh, yeah, that's a great picture.
Yeah. And remind me, I think they're coded up to a point, and then, yeah,
The last
2.7. Okay, good. 0.5, excuse me. Yeah, I can read. Next, that's a good picture. And then, do we have any more? This is just a cartoon, obviously, showing the electrocoagulant effect is a fancy term, just basically discrete cores of tissue that are created temporarily and it deposits energy in the distal tip. And then the nice thing is you can ratchet the depths to
Next slide.
to hit the depths, get the reticular dermis as well.
Okay.
All right. All right. All right. I think those are great. We'll go back live, please.
So Dr. Rodriguez just finishing the left side on the lateral simulinaris, and almost finished here. And then she's going to run these inscriptions. That's good right there. And then let's go 3 inscriptions. And she's overlapping by 50%, and then we're going to go right back and forth. So sort of a double pass with a 50% overlap. And that should give us a little bit more power in creating definition for this old guy, because he's going to have a great result. You can kind of see it coming. It really is looking nice. So I'm excited for him. I think he's going to be excited too. Hopefully he'll be able to take his shirt off in a week or two. And when the beach is open in 2 or 3 years, then we'll
It'll look real good.
yeah, he'll be ready.
I mean, he's a 54-year-old gentleman. Looks like he's
He's
way
a
younger,
very fit guy.
Very fit guy,
And,
but still.
I
it's a
think
big change.
COVID caught up with him. He had some lifestyle changes that caught up with him in regard to work, but this is really going to be a springboard really to a much more athletic appearance and a much more youthful lifestyle as well in regard to his travel and the things he does, you know. That's the beauty of plastic surgery. The things we do can change people's lives in a way that's meaningful. And it's not like real surgery where you're saving lives, but patients are so appreciative if you can give them a lifestyle that's different and give them self-confidence. And this device is really a great little plus for us.
Okay, great. Oh, yeah.
Okay, I think that's good.
And Henry, I'd like to comment on some of your great results in the last 3 slides, if you don't mind. Those are really nice. Can you make some comments on
okay.
with the female slide, please? Starting, 3D.
So this technology can be used in a lot of different ways, but here with this 3D sort of sculpting, we did abdominoplasty, Brazilian butt as well, but with the abdominoplasty, we did some architectural changes to give her a more athletic looking abdomen. And in this picture, really more by internal kind of sculpting of the abdominal flap. And she's pretty youthful. She's probably 7-8 years out now. She sends me a patient about every 6 weeks. You know, she really is a great advocate for me. And do the next slide, and you'll see on the next slide, we did the Brazilian butt part, but also I did etching on her back, and you can see the midline and sort of that paramuscular sort of roll. It was a very sexy lower back, and so you can etch that in with liposuction. And I think today I would also use Morpheus to give it a little bit more bonus there, but she was relatively tight skinned there, so it worked out well. But Morpheus there on that lower back for that architecture, I think I'd use as well.
Yeah, it's fantastic.
And then the last slide, this is a guy I did a while back, I mean probably 15, 17 years ago. And then you see a 5-year picture and a 10-year picture. And when patients stay fit, the architecture really holds exceptionally well. In fact, he looks more muscular. I think he got on testosterone, maybe.
Yeah, he's a little leaner.
But he's a little redder, too. Yes, but, you know, I think, you know, the surgery can be a springboard for patients for a healthier lifestyle, which is a wonderful thing.
And this gentleman has a natural asymmetry of his pec, looks like, too. So
right, the pec as well.
You just follow
Actually, he had chest, he had gynecomastia, had chest liposuction from a guy way back when. And we did sort of a adjustment on that. But the chest was sort of the harder part. He had some residual gynecomastia that had to be corrected as well. And then we also finished that as ab. And, but that's a good example of this surgery and the things we do, creating a lifestyle change that sticks for a long time, and greater opportunity for, for more fun. More beaches, testament. More vacations, with that kind of thing. So that's what we were after. I want to take more vacation. I need to get done. I'm not sure how much, Chris, we have left to offer.
No.
But
Dr. Mentz, this was fantastic. We can't thank you enough for inviting us with your Texas hospitality and your great staff here. I think just for the audience, you're going to probably finish up in a little bit of a flank section in a different position, but I think we hit all the bells and whistles. Any closing comments?
Well, I appreciate you coming very much, and I'm thankful to be a part of this production. I just want to say that the InMode technology has really been a gift to me, because it has allowed for more creativity, a little bit broader spectrum for patients, and I think it's a device that can make patients happy. And so I encourage everybody to give it a try. It's great polish for your cases. This guy would be loose. Remember how fat he was? This guy, can we have a picture here again? Here? Okay. But this guy would be exceptionally loose, and he looks really good right now. The skin looks pretty tight. He looks like he's 25 years old.
If you pull on it and bring it back.
I mean, this is going to be a great result, and I hope you're able to look at it in the end, and we'll send you some pictures.
Yeah, we'd love to have a follow-up. This will also be just a reminder in the InMode University Library, is actually get good viewership from there. Once again, thank you so much. We thank the patient most of all, a wonderful staff. And
well, thank everybody. Thank Lynn over here. Thank Abby over here. Thank Hilda over here. Thank Dr. Boo.
Dr. Boo up front. And everyone else.
And thank the video staff all together, and thank the audience.
Okay, thank you.
Thank you.